Good evening, and welcome to On Call with the Prairie Doc. The chemistry that takes place in our bodies is in the mix tonight. We process and sometimes produce the agents that control our functions, whether it's the raging hormones of a teenager or the onset of type 1 or 2 diabetes mellitus. The importance of these hormones and the balance that follows cannot be overemphasized. First, let's take a look at this week's Prairie Doc quiz question. Choose A or B. The people who are on insulin injections and are having roller coaster readings of blood sugars, sometimes very low in the 50s, sometimes above 300, are likely taking A, not enough insulin, B, too much insulin. Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We'll announce the answer and the winner at the end of the show, but you only have 10 minutes to get in your answer. We answer your medical questions, though, and you can call those all show long, and call about hormones, diabetes, thyroid, you name it, hormones. We want those questions, and if you call them in or send them to Facebook or email, call in the questions to 1-888-376-6225 or send us an email on the address on the screen. Joining us tonight to help answer your questions is Dr. Mark J. Oppenheimer. He's been practicing endocrinology in Sioux Falls since 1989. 2005, he opened the Oppenheimer Endocrinology Clinic. Dr. Oppenheimer is also a clinical associate professor at the University of South Dakota, Sanford School of Medicine, and a lot of his practice is at the Heart Hospital in Sioux Falls. Tell us a little bit about your background. Tell us a little bit about your dad.
My dad was a world-famous endocrinologist. He was responsible for the modern-day dosage of thyroid replacement. He was also did basic science work, finding the receptor site for T3, which is the active hormone. He lectured around the world, and
you went into endocrine because of him?
He told me not to go into endocrinology.
He did.
He said it's a dying area.
Yeah, it's not. It's not. So, and he did a lot of that work when he was at the University of Minnesota?
Correct. Well, he started out at Montefiore Hospital in the Bronx, and then came to University of Minnesota in the mid-'70s.
Okay, and that's where you grew up in Minneapolis?
I grew up in New York.
Oh, you're right.
Yeah, I think so.
Yeah. So you grew up in New York. Where did you go to school?
For college?
Yeah.
Princeton University.
So we went to Princeton. You were one of those what do they call those? Ivy Leagues?
Yeah.
Was that neat?
Yeah.
Oh.
I mean, you learn from the other students.
Yeah.
The teachers sort of follow you.
Yeah, okay. And then which med school?
University of Minnesota.
And then you practiced in Minneapolis for a while, and then decided to come to South Dakota.
I saw the light.
That's what I thought. So now you've been here since mid-'80s.
1989.
Late 80s. And you're, as a diabetologist and a thyroid expert, and I mean, what does your practice involve?
I get up early in the morning. I'm at the hospital at around 6 a.m. And then I do my inpatient work there. It's very important for me to get up early because I have to write all the insulin orders. And the insulin is given between 7:30 and 8 o'clock.
So you need to be there before that.
I got to be there before that.
Yeah.
And so, and probably of my inpatient, probably better than 90% is at the Heart Hospital, the Avera Heart Hospital.
Yes. Yes.
And I'm the only endocrinologist that goes there.
Right.
And so it's a lot of responsibility, and I have a great time. The nurses are fantastic.
And you're on 24/7, right?
I'm on 24/7.
Wow.
I am a dinosaur.
Yeah, you are. You are kind of a dinosaur, aren't you?
I love it.
But you have your practice. You have your office.
And then I have my office. I get to the office around 9, and I'm there with a lunch break till 3, and I see patients there, and I see from both sides of town, and I see from outside of town. I see people coming from Rapid City to see me, and I just have a great time.
So, yeah, most of your practice, though, involves complicated diabetic cases.
Probably around 50%.
So what else is the other part of your practice involved?
Just shooting the breeze.
No, yeah, I know shooting the breeze. But thyroid disease?
I see mainly diabetes and thyroid disease. That's the bread and butter.
Right.
Otherwise, as part of diabetes, you have to take care of patients' lipids. You have to take care of their blood pressure. You have to be like a real doctor, like you.
Yeah. So you take care of a lot of other things as well.
Yeah, and sometimes I'll see people who are referred to me for fatigue.
Right.
And they think, oh, I must have a thyroid problem. And my job at that point is to try and sort out what else might be going on and try and get them back to their family doctor to come up with a plan for them to succeed.
So what percentage of people who have diabetes are cared for by an endocrinologist, and what percentage are cared for by primary?
95% by primary care, 5% endocrinology. And it's interesting, in Sioux Falls is one of the rare places where there are too many endocrinologists. Other places, you talk to an endocrinologist and it may take 6 months to get in to see somebody.
They're inundated.
Absolutely inundated, way too few.
Why do you think that's the case?
I have no idea.
Great place to live.
Well, absolutely. When I came here, I was endocrinologist number 2.
Who was the first one?
Well, the first one left. That was Fred Leverin.
Oh, yeah. Is he still practicing?
I think he's semi-retired.
He was doing radiation, thyroid, and nuclear.
He was doing nuclear medicine.
Yeah.
He went. Yeah. And then number 2 was T.A. Schultz.
Right.
And he retired, I believe, in 2005.
And he's doing great, isn't he? I mean,
he's doing awesome.
You see him periodically. He's a great fella.
Wonderful.
Wonderful man. So the other things that people ask a lot about before we is testosterone. A lot of older guys come in and they go, I don't have any energy and I'm having trouble functioning. And so how do you approach a guy who's been to the primary care doctor, a testosterone level was low? What do you do then?
First thing I want to know is when the testosterone level was done. If it's in the afternoon, it could well be falsely low. The only way to check a testosterone level is in the morning.
Okay.
So let's assume if the testosterone level is low, and the normal range for testosterone is roughly over 300.
Right, normal's over 300.
Yeah.
So let's say you're 80. What should that guy's testosterone?
But most of them aren't 80. But most of them are in the 200 to 300 range, and that probably means
No, 80 years old.
Oh, they're 80 years old.
They're not 200 or 300 years old. I'm talking an 80-year-old guy.
You're very confusing.
I know I am. I've got that problem. So let's say we got an 80-year-old guy.
Yeah.
And his testosterone, what should a normal 80-year-old guy's testosterone be?
Probably over 200.
So let's say it's 100.
If it's, then you got to say to yourself, what am I trying to treat? What am I trying to find out?
Right. Okay.
And so if someone has a testosterone level of 100, if I put them on testosterone, how would that make their life different?
Right.
And most people who are 80 years old aren't that interested in life outside.
Return of sexual function.
Return of sexual function. And it probably doesn't make that much difference. But it might potentially help them out with their muscle strength. It might potentially help them out with their energy. And so there may be a rationale for even treating in that age group when you give them the right dose.
But the downside is there's a risk to testosterone. Let's talk a 50-year-old, 60-year-old, 70-year-old. You start giving them testosterone. I mean, there's a lot of ways to give it. You can give them the injection, the gels. The injection is way cheaper.
Yeah.
You can give it whatever way it is. You can't give them by pill.
Correct.
What's the downside? Prostate cancers, atrophy of the testicles. What is the downside?
Well, in a kid, you're going to take away their ability to have kids.
Okay.
And so,
but most 50-year-old guys are probably not worried about that.
Well, it depends who they marry.
It all depends, doesn't it? It does. So, all right, but
there really isn't that much of a downside. You can again, if you're given the appropriate dose, maybe your HDL will go down a little bit for whatever that's worth. But I don't see there's a significant downside. There are people who are talking about increased cardiovascular risk.
Right, but they made a big fuss about that.
That's probably not true.
Why do you say that?
I think the most recent studies have said that's nothing. It's not a cardiovascular risk.
It's right.
But the major problem I would have with testosterone therapy is when it hasn't been properly evaluated. So you have someone who's let's say they're 60 years old.
Right.
And they have a testosterone level of 100.
So what do you do? What's the next workup?
Well, first of all, if they have a 200 to 300, I might just watch.
Right.
But I think the next step is to check some pituitary hormones, an FSH and LH, or maybe just an LH, and you see whether it's high or low. LH stands for luteinizing hormone, which is the stimulator for testosterone. If someone has a low testosterone, low LH, then you're missing the signal to turn on the testicles.
So their problem is pituitary, not testicles.
Correct. And so then you say, well, what could be screwing up the pituitary? Well, you could have a big pituitary tumor. And that pituitary tumor might or might not be making stuff to screw up the rest of the body.
So how many people who are 60 with low testosterone are going to have a pituitary cause?
Small.
Very small.
Small.
Majority of them, they have
testicular failure.
Right. But a lot of these people are drinking too much, they're smoking, they're not exercising, they're not taking care of themselves, there's obesity problems and so on and so forth that can cause problems. Right.
But can those problems affect the testosterone?
Right.
I don't think.
It's not that big of a deal on the
testosterone. Not testosterone of 100.
But it will decrease your sexual function.
Yeah.
So if you want to improve sexual function, that would be the first thing to do.
Well, but someone else throw it through this level, and you got to address it.
Yeah, so the level is the issue, isn't it? All right. Finding a new lump or a bump can be a cause for concern, especially when your mind jumps to the worst possible scenario.
Cancer, right to cancer, yeah. A lump anywhere, that's the first thing that comes to mind. And yeah, I didn't know it was on my thyroid. You know, it was just, to me, it was on my neck or in my throat. And so that caused a concern. But, you know, then after they discovered it was in the thyroid, and after we did the test, of course, there's still the concern until they do get the final results back. This has been quite a few years ago already that I had this problem. I noticed it at an airport coming home from a meeting. Just one of those layover things, you sit there for a while and it's like, something's not right. And I went in the restroom and I could see it. I could see this lump in my throat. And it got big really fast. By the time I got home and got an appointment to get into the clinic, it had grown quite a bit already. And that was one of the concerns, was that it was growing so quickly. They start out by doing a scan of the thyroid, and that was inconclusive. And so from there, they did a fine needle biopsy, and again, inconclusive. And that's when they decided to do surgery. So I did a complete right lobectomy. And when the reports came back, it was a multinodular goiter. So no malignancy, but by taking the whole half of my thyroid, when they did that, then I have to be on the hormone replacement for that. And so I've been on that for quite a few years now. They always hoped that the other half of the thyroid might, you know, kick in and do its own thing, but it never did. It just kind of was lazy and let the drugs take care of it. Lack of iodine is one of the things that can cause a goiter. I don't know that they ever determined that was really what caused the goiter. We get iodine in a lot of our foods, not just iodized salt. Although I was not using iodized salt at the time, and I have used it ever since then. Well, you know, it's always a good idea to go in and have it checked out right away, because, like I said, I did the tests and the needle biopsy and everything, and it was still inconclusive. And certainly by the time it shows on the exterior of your body, it's already grown pretty good size. So even for a non-malignant goiter or tumor or whatever you wanted to call that, it can press on your vocal cords, it can cause an issue with your throat. So, you don't want it to block an airway or something. So it's always good to get it checked out right away. I mean, just the look of it for cosmetic purposes may not be that important of an issue, but the things that are, if it shows that much on the outside, it could be swollen that much on the inside too.
Thank you, Gail, for that. Gail's from DeSmet,
Where's DeSmet?
Oh, that's a wonderful town in this state. It's one of the great towns in the state. So she had a thyroid nodule. Now, a goiter, I mean, we have a picture of a goiter, and we've seen 2 pictures of goiters already that were brought up during that interview. How often are we seeing that now?
Rare.
We're just not seeing goiters anymore.
Well,
but there's a tendency to not use iodized salt.
Well, we have to define it, though. All a goiter means is an enlarged thyroid.
Right.
Enlarged thyroids are common, but they may be twice normal size, and people wouldn't notice it. What you saw in the pictures were humongous goiters, which are rarely seen. I've seen 2 or 3 of them in my career.
They saw large goiters in this area of the country, the goiter belt, because we didn't get salty fish, or we didn't get iodine from our fish. And if people don't take iodine in their iodized salt in this country, they're at risk for thyroid disease from it, correct?
Theoretically, I would think it'd be really, really hard to avoid salt, though. Have you ever eaten bread without salt?
Why would you not salt your bread or everything? I'm
talking about.
Yeah,
I have high blood pressure.
Yes.
And so naturally I try and do things without medicines. That's just like everybody else.
Right.
And so I naturally had to. What service? I had.
Here,
oh wow!
More coffee.
That's awesome.
Thank
awesome.
you.
Thank you. So I tasted what a non-iodized salt bread tastes like. It's like you can't eat it. It's hard to find food without salt in it. So people are trying to limit their salt to treat the blood pressure and that sort of stuff. It's a very controversial area, and I think that there are a lot of people with high blood pressure who don't respond to salt restrictions.
It's not a salt issue, right? I think I've heard this, and I believe it's true. I monitored this carefully. 1/3 of the people who have hypertension have some response to salt restriction, whereas most of us who have high blood pressure have it from other reasons.
Yeah.
And I think sleep apnea in particular. Thyroid nodule, thyroid disease. The majority are due to what? Hashimoto's?
Yeah, Hashimoto's just named after Mr. Hashimoto.
Right.
He wanted to be famous.
Yeah, and he got famous.
Right. And so it's just an immune response. An autoimmune disease is when the body eats itself up.
Right.
And so you have antibodies to the thyroid, and then if someone has those antibodies, that can be a cause of overactive or underactive thyroid, either way. Or people can just have the antibodies in their system.
Right. And that's the majority of people who get hypothyroid. And they have what kind of symptoms?
Most people have no symptoms.
Tired, malaise, fatigue, all that.
You can. If people worry about weight gain with hypothyroidism, that's usually 2 or 3 pounds.
Right.
It's minimal. It's usually fatigue,
dry skin,
constipation, cold.
Yeah, but those are, we see that with everything and nothing.
The vast majority of people who have those symptoms don't have thyroid disease.
Right, there you go. Well, we'll jump into questions, okay?
Okay.
80-year-old woman from Huron. Whenever I try to reduce my calories to drop weight, my blood sugar drops too low. What can I do to try to lose weight but not become hypoglycemic? So what about hypoglycemia? They're not on, there are a lot of people who talk about hypoglycemia, and they're not on insulin. Do you believe that's a real deal? Reactive hypoglycemia.
Well, we don't know enough about her question. She could easily be on insulin. She could be on a sulfonylurea. There are lots of things she could.
Glipizide, glyburide, one of those.
Yeah, one of those. And if you lose weight, you have to have the medicines cut back.
Right.
So the first thing they need to do is to talk to their doctor and say, I'm assuming that they do have diabetes.
Right.
And then they have to talk to their doctor and say, I want to lose weight. I'm running to low blood sugars. What should I do?
But there are people who have reactive hypoglycemia as they're coming into diabetes, or type 2 diabetes. Do you think that's a real deal? There's a lot of argument about that.
I have never been impressed by that.
Okay, you don't think it's that important?
No.
I do think it occurs. What the treatment, if you have it, is to eat more frequently and more proteins and less carbohydrates. What do you think about all this about carbohydrates in your diet if you're diabetic?
I think it's garbage.
You think, what's the important diet for a diabetic?
Calorie restriction.
Is calories, period.
A calorie is a calorie is a calorie. And if you're able to lose weight through when I talk about diet and exercise, the goal for me with my patients for exercise is 3 hours a week of aerobic. It's a half hour, 6 days a week. Most people could do that. You just have to remind them, and by the third or fourth year, maybe they start listening to you. And then I say it's maybe a 5-10% reduction in portion size. But to say, oh, we can't have any carbohydrates, I think that's a mistake.
Right.
I don't think it's ever been.
They get ketotic if you're only eating proteins or fats.
Well, but if you
Makes them sick.
There are three things you can eat. You can eat carbohydrates, protein, and fat. Okay, so I think most people would say for someone with diabetes who's at risk for heart disease to have nothing but fat would probably be a mistake.
Right.
To have nothing but protein, then you say, okay, first of all, how much protein can you eat? Standard diet would be roughly 15%. If you bring up to 25%, that's a lot of protein. And then once you have diabetes for a while, then there's higher protein diets are risk for kidney disease.
There you go. So I think a mixed bag, a balanced diet, fruits and
grains,
vegetables.
and vegetables.
We agree.
All right.
A woman from Sioux Falls, what do you do if you're at an insulin level of 220 before bed and even eat a half of an apple, but in the morning I'm at level of 82?
Medication, medication, medication.
So I think that there are many people that are over-insulined. I just see them, and it happens when in the nursing home, when somebody's prescribing insulin. It can happen anywhere, by any doctor. But I think many times too much insulin. What is your take on that?
Pharmaceuticals, agents, the people who make those drugs, they want to make profit. That's the only reason they're in business. They don't care about the patient. And so what happens is they have a drug, they need to push the drug, and they need to make it as accessible to people as possible. So what I see, the most common reason for that, for me, would be people who are on a whole mess of Lantus or Levemir. They're taking it once a day. And Lantus, Levemir, they don't know anything about meals. So the sugar can be normal or can be low in the morning, and then each time they eat, the sugars go up, and then it's 300 bedtime, and then 50 in the morning. Lantus and Levemir should not be used as by themselves. If they're going to be used, for the vast majority of people, they need to have insulin with meals also.
So your idea, and I think you're right, that you can, it's sort of like having an insulin pump but not having one. If you have a long-acting insulin and use short-acting insulin with the foods during the day.
Correct.
And you can do that as long as you don't have low sugars.
Correct.
A 74-year-old woman from Minnesota had a hysterectomy 36 years ago due to cysts and tumors, and she can't take any type of hormone drug due to endometriosis.
It's 76?
Yeah, that's what, 74. Still is having hot flashes 12 to 10 times a day. Is there any hormone drug she could take, or do the doctors have any advice as to what to help her with hot flashes? That's a tough one.
It is a tough one. I think
I like the idea of the SSRIs and the NRIs.
I'd put her on estrogen. I can't believe that she still has endometriosis at age 74. The data, the risk of having breast cancer, other problems with hormone replacements and low dose for 5-10 years probably minimal. And I would go to the doctor and try and get a low dose estrogen replacement.
There is a lot said about the risk of cancer of the breast and ovaries, but it's like in 10,000 women, 28 versus 18. I mean, you know, it raises it a little bit, but that percentage, that's a small number.
You know, what the listeners need to think about is when people make claims, something may have statistical significance, but absolutely no significance to someone's life.
Right.
And so, so it's very tricky to patients. It's tricky to doctors to be able to make that decision about what is really important, what is the real risk. One of my favorite concepts that I think that people can understand is number needed to treat. So if you want to bring your cholesterol down to a certain point, you've got to say, well, how many people would I have to treat to prevent one heart attack? And if I had 60 brothers and sisters and I was the only one, then do I want to go on extra medication to prevent that?
Yeah.
That's the question.
One out of 60.
One
or
out of 60.
One out of 800 if it's primary care. Or primary prevention.
You've got to ask yourself, is it worth it? Is it worth the side effects? Am I driving myself crazy for this?
Yeah, right. And I think that's such a point. I did obesity research when I was teaching at Emory, and our average weight person, and they were all women, was 350. And we did enough women so that our weight loss was better than the standard, which was the dietitian, right? The dietitian had an average weight loss in her patients of 1 pound. Well, they didn't gain. I think as if you would have done nothing, it would have gained. We had 5 pounds. Well, 5 pounds and 350 pounds.
You're good.
Yeah, but you think about it, that was after a year. We had 5 pounds less. The point is, it wasn't significant, really. But statistically, it was significant. Oh my gosh,
you were a great doctor.
Well, if you do enough people.
Absolutely.
So you can make statistically, so statistics can lie or lie more.
And again, the commercials you see on TV, lower your numbers, lower your A1C. You need to know whether for that particular drug, are there any effects that have actually been shown to prevent disease?
Right. And you know that if you get that sugars too low, the risk of death starts to rise again. It's a Y-shaped curve, right?
Not only death, but worse. I mean, I've had several people who've had problems with low blood sugars and they end up with dementia. They wipe out their thought process. They can't think anymore.
So you allow people a little higher sugars than lower sugars, particularly in the elderly population.
Absolutely, but even in the younger, so you got to see everything. When you see your doctor, it's the risk versus the benefit.
Right. We've got a question, woman from Watertown. What's your opinion of adrenal exhaustion? I've got a picture of the adrenal gland. This is the adrenal gland. This is the adrenal. This is the renal kidney, right? This is the kidney. This is the adrenal gland, right? This is the adrenal gland. It's on top of the renal gland. So tell us about adrenal exhaustion.
Adrenal exhaustion is not a medical term. It doesn't exist.
It sounds like somebody's been selling or something.
Absolutely. I mean, if someone is concerned about, the medical term is adrenal insufficiency.
And I see people who come in elderly and they're sick, and when they're sick, I don't sense that they have a adrenal gland that's working well enough, and I give them a bolus of methylprednisolone, and they do better. I mean, I think there's a time in a stressful scenario that their adrenal glands are inadequate when you're past 85. What do you think of that?
I would say
you'd argue that.
I would do something in addition. If before I gave that methylprednisolone, I would check a cortisol level.
Okay.
And that way you'll know for the future. If someone is in the intensive care unit, their cortisol level should probably be over 30.
Right.
And if they come back and they have a cortisol level of 60, you can just stop the steroids.
Right.
Because risk versus benefit. On the other hand, if they have a cortisol level of 15, you may want to treat them through that thing. They may or may not have adrenal insufficiency down the road.
All right.
It may need more evaluation, but you need to evaluate.
All right. Okay. After feeling aches and pains for almost 2 months and a rapid weight loss, one of our own production assistants here at On Call with the Prairie Doc went to her doctor to find out the reason.
I was weighing myself regularly, and I could tell that I was losing 1 to 2 pounds every day, and I got down to 108 pounds, and I said to my mom, I was like, Mom, I weigh 108 pounds. This isn't okay. And she said, well, it's probably something that's dietary. We don't know what it is. And then after we spent some time together, she saw that I had all the classic symptoms, the excessive thirst, the weight loss, the sweet breath, everything. And she said that she was taking me to see a doctor. And then on my way there, she told me that she thought I had diabetes, and she was right. On my way back home, after they had taken my labs, they didn't want to determine if I had diabetes or anything, and my mom got a phone call and they said, your daughter has a blood sugar of 789. Either you come back to the hospital and we give her insulin, or you might as well drive to Sioux Falls and take her to the ER. When my blood sugar is low, I feel clammy, I feel sweaty, I'm irritable, I have sudden mood change, I feel shaky, like my left hand in particular really shakes, like it really tremors. My vision is blurry. I just basically feel like I'm shutting down. Usually when I wake up or right before I eat breakfast, I have to measure my blood sugar, and it's supposed to be between 80 and 120, and then I eat my breakfast, and then I take my insulin, and I do that with every meal. I measure my blood sugar before, and then I take my insulin after, and then at night I have to take more insulin just to kind of keep me at the steady level that I need to be at. I have to measure my blood sugar as needed. Like if I feel low, which I feel all the 8 signs and symptoms when I feel low, I have to measure my blood sugar. So 4 times minimum is how often I measure it per day, and then I have to take insulin at least 4 times a day. Being a diabetic, you really have to prepare. I have to measure out all of my food so I know approximately how much I'm eating, when I'm eating it. I always have to carry my insulin with me. I always have to carry snacks, a juice box, and needles, and my blood testing. It's a lot of work, but I will do it to make myself feel better. I'm trying to eat more vegetables because non-starchy vegetables hardly count as any carbs. But one thing that I do notice is I'm gonna have to change my taste because I don't really like green vegetables, but I notice that by the end of the day, I'm still hungry because I'm used to eating such hearty, carbohydrate-filled meals that I'm not satisfying my hunger the way I should. I would say the most difficult thing about having type 1 diabetes is making people understand that it's not going away. It's not like your grandparents' type 2 diabetes where it can be treatable, where it can go away. You have this for the rest of your life and it's not going away. Actually, I looked up a statistic, only 5% of diabetics have type 1 diabetes. So there's not a lot of people out there that have it, but more and more each day I'm finding more people who do have it, more people who can relate.
Thank you for doing that. It's interesting that you talked about injecting it in our arms. You prefer injection sites on the belly?
Yeah. I go around in a circle like that, and the advantage is just injecting the abdomen is you have more consistent absorption, and you have lots of sites that you could do that in. If you overuse certain sites, and you avoid right around the belly button. But if you overuse sites, you can get buildup of fibrous tissue, and if you have that, then you're going to have inconsistent absorption of the insulin.
And that's your key. She has since this production got a pump. Mm-hmm. So tell us a little bit about the pump and why that might be better for her.
The major advantage of the pump is that people are familiar with background insulins, like Lantus and Levemir.
Just kind of a steady background.
Steady background. But the disadvantage of that is if you are active, if you are going to exercise, you have 2 choices. Either you don't exercise, or if every time you exercise you have to take extra foods to avoid going low.
You gain weight.
And you gain weight and feel lousy. And not too many people who are trying to play basketball really want to stuff their faces with food right before they're exercising.
Right.
The nice thing about the pump is that you can turn down that background insulin. 15 seconds, you could be done with it, and you could be on a temporary background.
Right.
And so it gives people who are young, healthy, who have the advantage of adjusting themselves.
Right. Now, do you think that we're very far from a point where we're going to have a glucose monitor that automatically tells your pump to give or slow down insulin, and it'll be done automatically?
That's been promised to me since I started practice.
Right.
Right now, what is available is a combination of a pump and continuous glucose monitoring system. The thing that people need to understand is that the continuous glucose monitoring system does not monitor blood sugars.
It monitors.
Interstitial fluid. And so
It's a lag, then it doesn't show the lows or the highs.
It's not consistent, it's not accurate. And so if the pump was to depend upon that, it's a setup for failure.
Right.
Now what's available now is if the sugars are low, it can talk to the pump and turn the pump off if nothing has happened
Right.
with the patient.
Okay.
Doing something with the pump. That is available now.
Okay. Let's go to questions. Would you talk a little bit about the special problems of type 1 versus type 2 diabetes? For example, type 2 is most of the time controlled by pills, correct? Mm-hmm. And is way more inherited than type 1.
That's true.
But why is there a difference? Explain it more.
Type 1 can occur at any age. It's most common.
And this was a young adult.
Yeah.
So we used to call it juvenile onset, but it's not.
But
always.
you can get type 1 at age 80. I mean, that's conceivable. So just like you can theoretically get type 2 when you're very young.
So what is the pathophysiology of type 1 then?
Type 1 is an absolute insulin deficiency.
So you don't have enough insulin.
You don't have enough. You're squeezing, trying to get water out of that rock.
Okay. And people who are older might have it because they've some immune system or something, but kids who are 15 or woman suddenly gets full blasted type 1 diabetes. What happened?
Their pancreases are shutting down. Their beta cells are in trouble.
And we think that that's an immunological thing.
Correct.
Okay.
But we don't know the cause.
We don't.
I mean, people have been arguing about that 30, 50 years.
Right.
We'll never know.
We're not going to know. You don't think we'll ever know?
Well, I went to the wrong line of work. I would have figured it out.
Yeah. All right. So I think that's it. It's really, and type 2, people have resistance.
Resistance.
So you have, when you get overweight, for example, you have to have a whole lot more insulin to counter the problems, and weight begats.
If you measure insulin levels in a type 2, they might be high, but not high enough.
There it is. I think then there's a lot of people that I take care of who have type 1 and 2. They've had 2 for a long time, and now they're just failing.
I call that type 1.5.
Yeah. And do you see a lot of it?
Oh yeah. It's very, very common for people who have had type 2 for a long time to not respond to the medications anymore, and then they need to be on insulin.
Okay. Now, we talked about thyroid, but we didn't talk about parathyroid. Is that the same thing? What is parathyroid?
There are 4 parathyroids. Para means right by. So it's 4 glands that are very small right next to the thyroid. And you can have...
Keep going, and I'll just get this picture.
You do that.
Okay.
And so if someone has hyperparathyroidism, that means they have a high calcium, and that can cause the bones to be weak. It can cause, if it gets bad enough, people can lose memory. People can be at risk for psychiatric disease, from heart disease, depression. It can be really nasty. Most of the time when people have high calciums, they have no symptoms whatsoever.
So, you know, something struck me today. I have a case of a person who has documented hyperparathyroid. I made this diagnosis.
Yeah.
She presented with hypercalcemia, and of course, I've kind of carte blanche put everybody on vitamin D. She got hypercalcemic. I stopped the vitamin D.
Yeah.
And then later, I checked her parathyroid level, and it was sky high. Well, she's got a vitamin D level now of 12, normal being above 30.
Yeah.
So she's hypovitamin D, and her calcium is kind of balanced, and she's got hyperparathyroid.
Yeah.
Do you see that?
Yeah. Yeah. It's very... It's very common for people with hyperparathyroidism, high calciums, to have low vitamin D levels. You do not want to treat the vitamin D because you're basically going to fuel the fire.
Right. So you have to let them be vitamin D deficient.
Or you treat the hyperparathyroidism with surgery.
Right. And so here's a picture of the thyroid gland, and this is the thyroid, and then there's 4 little buttons behind the thyroid, which reflect the parathyroid glands.
Correct.
But people can have parathyroid glands elsewhere too.
Correct.
Can't they? Where else?
They could be in the thyroid. They could be into the chest. One of the things we're taught as residents is the best localizing procedure to find the bum parathyroid is to find a good surgeon.
Oh, is that right? And she or he will help you find that.
Absolutely.
There's what you have to do.
Absolutely. They are very, very good.
So you remove them, you find out that they're balanced, and then you make sure that they don't have MEN syndrome.
You probably want to do that before.
So let's talk about MEN syndrome, thyroid, parathyroid diseases. What is it?
Okay. Now this is...
Just in 2 sentences.
With multiple endocrine neoplasia,
Right.
Multiple cancers, you can have pituitary parathyroid pancreas.
Yes.
That's one of them, and and then there's another one where you could have where you have adrenal. You can have pheochromocytoma. You can have medullary carcinoma of the thyroid and pituitary. And then the parathyroid.
And I'll summarize it. MEN syndrome is why we have endocrinologists. I go, could be a MEN. I'll do a few tests, but I'll send them in your way.
And then I'll look it up real quick.
That's because it's complicated.
It's very rare. I think I've seen one MEN patient my entire career. But you got to think about it.
I have a Zollinger-Ellison patient right now, has elevated gastrin levels, hyperparathyroid, and we're working her up.
Good for you.
Why is it that I'm hypoglycemic when I sleep, but not hyperglycemic? So hypoglycemic when I sleep, but not hyper. In other words, I think this person is on insulin and they get low at night.
Yeah.
And what do you call that?
I call that you need to adjust get on the right regimen of insulin.
Too much insulin.
Inappropriate distribution of insulin.
All right. Not given at the right time.
Or the right types. There are multiple types of insulin.
Yes, there are. And that's interesting. We talked about different kinds of insulin, and I've used Lantus, I've used the other long-acting, but I know that you use a different one, and tonight I realized why. So tell me quickly, very quickly, because we got a ton of questions. Okay,
there's long-acting insulin, there's very short-acting insulin. That's the Lantus and the Novolog or Humalog.
Right.
Those are roughly $250 per bottle cash.
Right.
My patients aren't rich. If instead you go to Walmart or Sam's and you can use an older insulin that's available generic, it's $25 a bottle.
What is it called?
NPH regular.
So you need to use NPH regular.
There are 2 different types of insulin. You mix the 2 of them, take it twice a day before breakfast and before supper. Works like a charm.
And it's cheap.
And it's dirt cheap.
Are doctors in training at USD Medical School ever told to do palpation of the thyroid in an annual physical?
I didn't go to med school here.
But you were taught to do that.
I was taught how to do it, but I didn't. But to be fair, I couldn't feel a thyroid nodule until I was well into my fellowship, because people aren't taught how to do it correctly. And I would wager that at least 75% of primary care doctors don't know how to feel a thyroid correctly.
And I can tell you that I've felt a lot of thyroids. I've gone my whole life doing it, and I'm not very good at it. It's hard to do, and it is not very productive. So you can understand why sometimes these people don't get into it. But
They should try.
We are less and less using the exam that we should be doing and the history taking and too much getting into our technology. Don't you agree?
I think the problem is the training, and that people, that the family practitioners, the people who do internal medicine, they do rotations. They don't do endocrinology. They're more interested in the sexy stuff like the cardiologists.
Yeah.
They want to save lives.
Yeah, well, you save lives. That's 30-year-old male with Sioux Falls asked, about 10 years, I quit smoking, heavy drinking, started to break out all over my back with pimples. Do you think it's a hormone imbalance? Might be testosterone excess.
It's possible, but if he's taking extra testosterone.
Certainly one of the things that could happen.
Yeah, I mean, I've seen people who lift weights who take testosterone.
But I can tell you that if you've been smoking and drinking, your testosterone levels are low. You stop smoking and drinking, it comes back up.
But it's not going to cause, you think it could cause that? It's possible.
It's very possible. I mean, he may be a guy when he's just never been sober enough for his body to give it a chance. Maybe.
Possible.
Possible. I do think that when you've got what's called acne conglobata, like this bad acne on the back, you need to be touching base with your primary care doctor and making sure your thyroid and your hormone balance is tested. We've got one quick question. Younger male in the 30s, necrotizing pancreatitis that's greatly overweight with high lipids, both 1 and 2 type diabetes. Can you talk a little bit about necrotizing pancreatitis? And you've got 10 seconds. I'm sorry.
Basically, there are the pancreas has to do
One sentence.
See your doctor.
There you go. And now for the winner of tonight's Prairie Doc quiz question. People who are on insulin injections and are having roller coaster readings of blood sugar, sometimes very low in the 50s, sometimes above 300, are likely taking A, not enough insulin, B, too much insulin. The answer is B, and we're going to talk about this, but too much insulin. It was Ruth Lindsay from Brookings who answered the question correctly. Thank you, Ruth, for participating, and a book will be in the mail to you soon. So what do you think? You thought the answer was C.
Correct.
Explain that.
Because we talked about a little bit earlier, if you're just on Lantus, and let's say you're taking 50 units just to throw it up.
Right.
You may get too much insulin overnight and not enough during the day when you've got meals. So the 50 units may be absolutely correct, but you may need to take half of it in terms of short acting and half of it long acting.
So it's the timing, not the amount of it.
It's the timing, it's the amount of insulin, it's monitoring your blood sugars throughout the day and occasionally at 2 a.m. And you give the doctor the information and their hands aren't tied behind their backs.
All right. We'll be right back after this.
As your baby grows, there are new surprises and adventures every day. With each new milestone, remember, immunizations are safe and one of the best ways to protect against serious diseases, especially between birth and age 5.
Now that my grandson Henry has reached his first birthday and our granddaughter Stella has arrived, we're making sure that they stay on their immunization schedules.
Schedule your children's immunizations today, for baby's sake.
Balance is so important. For example, too much food causes obesity. Too little food causes starvation and sometimes death. Like Goldilocks, our bodies are always in search of balance. Not too much or too little, but that which is just right. It's sweet news that a healthy pancreas makes a hormone called insulin to keep blood sugars from going too high. When something goes wrong and either the pancreas fails to make enough insulin or the body becomes resistant to it, diabetes mellitus with elevated sugars will occur. This, however, is only half the story. What happens to keep the blood sugars from going too low? A couple of years ago, a patient of mine came in having sporadic nervous spells of fast heart rate, tremors, sweating, hunger, butterflies in the stomach, and poor sleep with night sweats. These spells were all from low sugars, which he documented on his home blood sugar monitor. He wasn't taking insulin or medications that lower sugar, was eating correctly, not drinking alcohol, and not excessively exercising. His was a rare case of a pancreatic insulin-making tumor. And after tests supported that diagnosis, referral to an endocrinologist allowed for effective treatment. Last week, I spoke to a middle-aged woman who once daily was taking long-acting insulin and multiple times daily short-acting insulin before meals and as needed depending upon measured blood sugar levels. She had been experiencing roller coaster sugar levels, sometimes above 300, but far more dangerous, sometimes below 70, with nervous spells similar to the man with the pancreatic tumor. The spells were happening from too much insulin. And nowadays, this situation is too common. These are two different causes for low sugars, and there are others, but for whatever reason, low sugars can deteriorate brain function, and when low enough, bring on loss of consciousness and even death. We've learned that when blood sugars drop much below 70, the body produces 5 different hormones to bring it back up. It's that important. The list includes well-known hormones like adrenaline and cortisol, and some lesser known like glucagon, noradrenaline, and growth hormone. Once sugars go too low, it's a week before these hormones settle down, making it extraordinarily difficult to find the correct dose of insulin. Of course, enough insulin is important in preventing complications from elevated blood sugars and diabetes mellitus. But when there's too much insulin, dosing becomes more difficult and the danger becomes more significant. That's why balance is so important, and we need to get that insulin dose just right. A big thank you to our guest, Dr. Mark Oppenheimer. Mark, it's been sweet of you to come on our show, pun intended. Sorry.
Absolutely.
Viewers have asked if there is a way to get a copy of our book, The Picture of Health, besides winning the quiz question. Go to our website, prairiedoc.org, and click on the donate button. And there you may join in and help by underwriting our efforts for honest science-based public health education. Please follow the directions there and send your deductible gift to the Healing Words Foundation. For gifts of $100 or more, I'll send you a personalized autographed copy. Thank you in advance for your generosity and support of these efforts to improve the lives of viewers like you. Well, that does it for tonight from all of us here at On Call with the Prairie Doc. Until next time, stay healthy out there, people.
But then plants begin to bloom and our noses begin to run. And climate change is making it worse. Springtime allergies. Next time, On Call with the Prairie Doc.
Funding for On Call with the Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, an organization working with the state's healthcare community to improve quality of care as part of the Great Plains Quality Innovation Network. Additional funding is provided by Aberdeen Asthma and Allergy, Avera Heart Hospital, Brookings Health System, Dakota Allergy and Asthma, Dakota Care, Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, South Dakota State Medical Association, Swiftel Communications, and Vance Thompson Vision. Closed captioning for On Call with the Prairie Doc is provided by Avera, Brookings Health System, and Fishback Financial Corporation.
Prairie Doc after hours. We had many great questions submitted beyond what we could answer during the broadcast portion of our show, so let's get started.
Go for it.
70-year-old woman from Sinai, blood calcium of 10.6, parathormone level of 77. I don't know what the normals are. I always have to look it up.
65.
So above 65 is too high.
Correct.
So she's got hyperparathyroid with a secondary hypercalcemia. Calcium is elevated, parathyroid level is
It's
low.
primary hypercalcemia.
Okay.
High calcium because of the high PTH level.
All right. Numbers from a 24-hour urinalysis. Should I be concerned of overactive parathyroid glands or tumors? If tumors are a risk concern, what symptoms should I look out for? I know that for a long time when we started doing big panels in practice, because it was just as cheap to get a full panel of 12. Calcium was one of those things. We would catch hypercalcemia we'd never catch before. So we found all these kind of borderline hyperparathyroid, and we kind of sat on them.
That's what we should do.
That's what you think for the most part.
For a 70-year-old with a calcium of 10.6, I wouldn't touch it.
Okay.
I'd recheck in 6 months.
All right. Now, I mean, what about vitamin D? I mean, if we gave this person vitamin D, if you should check their vitamin D level too, wouldn't it? Would you not?
Well,
you don't want to give them vitamin D though.
You don't want to give them vitamin D. The question is, why would you want to check the vitamin D level? Let's suppose the vitamin D level is low. You give them vitamin D, you cause their calcium to go high, and then you're putting yourself into a situation where you need to have surgery.
Right.
If if the vitamin D level is normal, then it's cleaner. But I'm not sure I would check a vitamin D level. I'm not sure I really want to know.
I've had a patient who I started on vitamin D, calcium went high, stopped the vitamin D, calcium was still kind of borderline, parathyroid level was high, but the calcium level was 10.5, and I just sat on it. She was in her 70s and 80s.
The one thing that I would probably do that we haven't talked about is do a bone density.
Make sure that they're...
If someone let's take that same 70-year-old.
Right.
They have vitamin D level of low. They have calcium of 10.6, and then they have frank osteoporosis.
Right.
I would do surgery.
You'd get rid of the parathyroid.
I would do a localizing procedure.
And remove the tumor.
Yeah, and then supplement the vitamin D.
And you would probably do that way into their 70s, but not into their 80s.
Depends upon how bad the osteoporosis is.
It depends upon how active
and how active they are
person.
and that sort of stuff.
Yeah. We have a question. 80-year-old woman taking 10 milligrams of the medication lisinopril, which is a great drug. I think it's #1.
It's a great drug.
Choice for high blood pressure. Is it okay to take 325 milligrams of aspirin with it as well?
As long as there's no reason not to take the aspirin.
Right. What are the reasons not to take the aspirin?
Mainly, I would think in terms of bleeding.
Right. You know, the danger.
I mean, it's got to be very, very small.
Aspirin, you know, they did this huge study on male physicians, and half were on aspirin, half were on placebo, so they didn't know. And the answer was the people on the aspirin had less heart attacks, but more bleeds, than the person without aspirin, and it was a push. And so they said, well, if you're a healthy middle-aged male, don't take aspirin because it doesn't benefit you, or the benefit it does is outweighed by the risks, except they didn't talk about colon polyps because colon polyps are clearly benefited by aspirin.
The other thing is you can have it's more tendency towards reflux even with small dose of aspirin, as case control.
Heartburn.
Yeah.
You're the case.
I'm the case. I believe there's an article in one of the journals where they talked about eye findings with people with aspirin.
With little bleeds.
Well, not with bleeds, but I think it may have been a macular problem.
Huh.
New England Journal of Medicine, probably about 8 years ago. Huh. And I stopped taking aspirin after that. I don't take any aspirin.
I do take a baby aspirin, but it's because of colon polyps, because the studies show that 81 milligrams of aspirin for colon polyps is way better than 325 for colon polyps.
Yeah.
And if you're going to do it for vascular disease, it works as well and it should have less problem with heartburn, right?
I would think so.
So, the argument, we could go on and on all night long.
Dual.
Is there a connection between restless leg syndrome and hypothyroidism, and how should restless leg syndrome be treated?
The answer from the endocrinologist is if you have symptoms of restless leg, you check a thyroid level. If the thyroid level is normal, then it's not from the thyroid. And then you go back to your primary care doctor and have him treat your restless legs.
So there's a lot of answers for restless leg. A lot, as I say, is stretch your legs, get into a regular exercise program, make it regular. Don't make it intermittent, because intermittent exercise can bring on leg cramps and restless leg. There are certain medicines that you can use, and it's a huge debated issue. I mean, we used to use Parkinson medicines, but then they get resistant. It would accelerate it. Mm-hmm. So you've not messed with the Parkinson meds for restless leg?
No. I use for pituitary tumors, the bromocriptines, that sort of stuff.
Yeah.
But that's it.
The other thing about restless leg is you got to make absolutely sure you don't have iron deficiency.
You're the expert in restless legs.
What do you, let's see if I can get this to go up. What do you consider a normal fasting blood sugar range for a person over 60?
There's the normal, to have diabetes, regardless of the age, you need to have 2 fasting blood sugars in excess of 126, regardless of your age. Now, normal blood sugar would probably be less than 105. Now, there's a difference between what's normal and what needs to be treated.
So what needs to be treated?
That depends upon the age, and it depends upon what the life expectancy of the person is. I'm going to, if someone is 85 years old and they've got a sugar of 140 fasting, I'm going to leave them alone.
Right.
I weigh the risks versus the benefits.
Do you use hemoglobin A1Cs? Now that's another way of managing a 3-month average blood sugar. Do you use hemoglobin A1Cs to guide your therapy much?
Yes and no. It's a tool. But the problem with the A1C is that there are problems with the A1C. If someone has kidney issues, instead of the red cells lasting 3 months, which is what you're quoting, they only last 6 weeks. So the hemoglobin A1C can be artificially low, and the doctor can be misled into thinking that the blood sugars are fairly well controlled. So you have to keep that into account. Same thing if someone has red blood cells that are smashing each other, hemolysis.
Hemolytic.
The red cells aren't going to last 3 months, so you can have an artificially low A1C. So I look at the A1C, I absolutely do, but there are times the A1C is not accurate. I depend a lot on home glucose monitoring, and if something doesn't make sense, I will check something called a fructosamine, which is a 2 to 4 week check, and has really been very helpful to me to confirm whether the A1C is right or not.
And what are the things, again, that will lower it? Hemolytic hemolysis or hemolytic process.
Hemolysis, renal failure.
Okay. Wow. And I think we're at the end. I just want to say, let's see if there's, I think we're good. Mark, I just can't tell you how much I appreciate you joining us, and I'm going to give you twice as much as what I'm making this year.
Oh, you are so generous.
For this visit for coming for
Hey, I love this. I love it.
Thank you so much.
My pleasure.
Okay. And thank you for joining us on our website. We appreciate all of your questions and the opportunity to answer them. And until next time, from all of us at On Call with the Prairie Doc, stay healthy out there, people.